There are a couple of more questions that I think it's important are coming regarding liquid biopsy. And the first question, which I think it's important to reiterate again, even though Dr. Marks, you did mention it in your talk. So is obtaining tissue from the resected specimen in this case, or any kind of metastatic specimen, um, provides more in-depth testing, which is not available on a liquid biopsy. If you can just highlight again the difference, what does liquid misses and what does it gains, and what is the tissue gains and what it can be missing? Because I think it's very important.
Absolutely. Yeah, no, that's a great question. So with comprehensive testing on tissue, ideally we're getting a next generation sequencing with looking at DNA sequencing as well as RNA sequencing. So this is identifying smaller mutations when we're doing them complementary together. And so when you get that report back, you're not just getting, information about the one single gene. You're getting often whole exomic information and whole transcriptomic information to really identify what's going on with the tumor as a whole. Some platforms have PD-L1 incorporated into that, but all of these individual things help to inform treatment decisions. And so I guess the other thing is liquid biopsy specifically, most platforms, if not all that I'm aware of, unless they're not necessarily approved yet, are only using DNA next generation sequencing. And so not only is the shedding of the tumor, you have to have a high enough tumor burden to detect an alteration, but it's only using one of those modalities, that being often DNA next generation sequencing. So you could miss a small indel or like the METexon 14 skipping mutation on a liquid biopsy that you might be able to detect on tissue. And so they need to be used together and with caution, with all of the potential pros and cons about missing such alterations. Last thing I'll say is, for example, if you're doing a biopsy and you get a specimen that shows a KRAS mutation, it's becoming more important. Well, what KRAS mutation is it? Is it KRAS G12D, or is it V, or is it C? We only have targeted therapies for certain mutations right now, but that we also have clinical trials in those spaces too. But then STK11 and KEAP1 are co-mutations that may inform further treatment decisions. And so the comprehensive testing can help to guide your clinician, and you might not get that whole profile with just doing the liquid testing alone.